Hello, and thank you for joining us. On behalf of the Southeast Mental Health Technology Transfer Center, we welcome you to today's webinar event entitled Housing First Ends Homelessness: Successful City, State, and Federal Programs. My name is Stephanie Tapscott, and joining me today for the moderation of today's event is the Southeast MHTTC Director, Dr. Benjamin Dress. But before we begin, I'd like to review a few housekeeping items. Please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration.
Oh, okay. Let me try and forward it to you.
I've got my presentation.
Our
ready to
center
go, but I can't.
and the larger MHTTC network use affirming, respectful, and recovery-oriented language. The Southeast Mental Health Technology Transfer Center is proud to serve the 8 states in HHS Region 4, and we invite you to visit our website to learn more about our center and hear about upcoming events. This event is being recorded and will be made available on our website for on-demand viewing soon. We encourage you to share your comments and thoughts throughout today's presentation by using the chat feature found at the bottom of your screen. Please remember to select chat with all attendees if you would like to share with everyone. We have allotted time at the end for our panelists to answer questions. Please submit your questions using the Q&A feature also found at the bottom of the screen. And finally, for those who are interested in a certificate of attendance, you will be able to download that after completion of our evaluation surveys. And now I'll turn it over to Dr. Dress, who will introduce today's panelists.
Good afternoon or good morning, depending on where you are. It's really a privilege and an honor for me to introduce our panelists for today's webinar. First, Dr. Sam Semberis founded Pathways to Housing in New York City in 1992, based on the belief that housing is a basic human right. Based on the belief that people experiencing homelessness and struggling with mental illness or addiction should not have to prove that they are housing ready. And based on a program philosophy founded in love, respect, and creating possibilities. At Pathways to Housing, Semberis and a team that included program participants and advocates for consumer rights and housing rights developed a model that came to be known as Housing First, a program that provides immediate access to permanent housing and person-centered supports to people experiencing homelessness and struggling with problems of mental health and addiction. We will also have Anthony Love. Anthony Love currently serves as the principal advisor and director of community engagement for the VA Homeless Programs Office. He provides strategic advice and counsel to the executive director on intra and interagency initiatives, as well as builds community relationships to help veterans exit homelessness. James Massey is the administrator of Milwaukee County Housing Services. James administers Milwaukee County's various housing programs to include the Milwaukee County Housing Authority Home and CDBG homeless programs and real estate development. James is the author of Milwaukee County's plan to end chronic homelessness and has over 25 years of experience in housing and mental health. Finally, Maxwell Ruppensberg serves as the director of the Office of Supportive Housing with the Georgia Department of Behavioral Health and Developmental Disabilities, DBHDD. OSH is responsible for the Georgia Housing Voucher Program, Georgia's project for assistance in transition from homelessness path program, and the SSI/SSDI Outreach Access and Recovery Program, all of which serve individuals with a psychiatric disability who are experiencing homelessness using a housing first approach. So with that, I just, I'm very excited to hear from all of you. Thank you so much for joining, and I'll hand it over to Sam. Thank you.
Thank you, Dr. Druss. Thank you for inviting us to present at this wonderful webinar. And thanks to all the participants for joining today. In this 45-minute presentation, or 50 minutes that we have left, we want to reveal to you a well-kept secret about homelessness in this country. The secret, which we want to share with you, the public, policymakers, through conferences, writing, media, events, and presentations like this one, is that we want everyone to know that we can end homelessness in the United States. The presentation describes a program called Housing First, and how this program and the program's principles are used to end homelessness, not only for one person at a time, but as you will soon hear from our panelists, how the program is used to reduce homelessness as an entire city, across a state, and for the veteran population across the nation. I have some slides to take us through this. I hope I can share them effectively. Is the slide showing okay? Anybody? Is the slide showing on the screen? Yes?
Looks great.
Okay.
It's
Yes.
not quite in presentation mode,
It's not in presentation mode.
but we can see it.
Okay. How do I put it in presentation mode? Okay, I'll just go with this. Is it readable? Because I don't really know.
Yeah, it's fine. If you want to go to presentation mode, just go to slideshow up on the top. But this is also okay. Whatever works best for you.
Okay, slideshow. Like that. Okay. Okay, I'm sorry. I don't really. Okay, so we're going to look at some of the reasons why we haven't ended homelessness. I'll start with that. So that, we are going to talk about how we end homelessness, but I'm going to talk first about why we haven't ended it. And in this slide, there's a number of reasons listed why we haven't ended homelessness. And what you do not see here are the usual suspects, the individual characteristics or pathologies that are usually associated with the mainstream media description of homelessness. Nothing here about mental illness, addiction, lack of motivation, or chooses to be homeless. Does that surprise anyone, I wonder? We're going to make the case here that homelessness is a systemic problem, not an individual problem, that this is listed among these reasons, starting with the first one, which says that we don't have national agreement about the root causes of homelessness. That's what this refers to. Without consensus about what causes homelessness, root causes, we don't have a unified national policy about how to address it. And because we disagree, we push and pull for programs doing things and going in opposite directions, and we get nowhere. Do we build more shelters? Do we build more affordable housing? What kind of housing? Tiny homes, encampments, safe parking? Does everyone get housing, or only those that are sober and working? Should more people be arrested? There seems to be a lot of criminality among the homeless. We frequently fund and defund projects according to a headline or political pressure rather than based on scientific evidence. We're not alone in homelessness. There are many other examples of this kind of national confusion about public health policy that result in terrible consequences for those affected. Let's just think back to the pandemic, 21, 22, at the height of the pandemic, and the debates about wearing masks or not wearing masks, opening business and not opening business. In one news article at that time, epidemiologists from around the globe were asked why they thought the US had the highest death rates, and they identified two key reasons. One, lack of national consensus on COVID policy, and two, a strongly held value of individualism. These factors are also root causes of homelessness that in countries, and we see this because in countries with greater consensus on what to do and stronger social contracts, for example, including the national belief that housing is a basic human right or healthcare is a right, those countries report fewer numbers of people experiencing homelessness, and they're more effective at addressing it. In the US, most people, the mainstream belief system around homelessness is that people are homeless as a result of individual problems. And our homeless industrial complex, if you will, like that vast array of services that serves people who are homeless, is really designed to fix or help or punish the person. There's a lot of investment in it. That slide showing all the dots across the country shows the shelter system, both private, public, faith-based, about a $10.7 billion a year industry. And in one study recently reports that about half of the beds are vacant on any given night. And of course, we have other programs, food, clothing, shelter, enforcement, transitional housing. However, all of these types of programs, emergency programs they're called, operate to manage homelessness, not to end it. In other words, you could be a regular client of any of these programs that are called emergency programs for years and still be homeless. Just a step back a bit, and who are people who are homeless and where are they and all of that. This is a slide that shows you the national count. Every year we do a one-night count, one night, usually in the middle of January. And this map gives you the per capita rates of homelessness. And a quick eyeball, you'll see that on the coasts, including Florida and Georgia, you have the greatest number of people who are homeless. There's about 580,000 was the 22 count. It goes up steadily every year by a few percentage points. By homeless, we mean people in shelters and literally on the street, or those we can find in cars. Mostly men, and everywhere in the country, minority groups are overrepresented, anywhere between 2 and 20 times their rate in the population. You'll hear from Milwaukee, I think the percentage of African-American among the homeless population is somewhere around 90%, and I think the same is true for Atlanta. So there's a racial, and there's a huge economic issue here, because what you can see visually is that homelessness is also more frequent in the states where prosperity is greatest. Where business is doing best, homelessness is highest. There's an absolute correlation between prosperity and homelessness that way. We are not going to talk about all of homelessness. Everything I'm going to say going forward, and also my colleagues will be talking about primarily the group of people who are homeless for a long time, what we call the chronically homeless. Most people who are homeless for about 2 months, which has some implications for the one-night count, because they're only counting the people that are homeless during the 2 months in January. There are 6 other times that turns over, making the number really closer to about 3 million. But that's the numbers, and we're not talking about that on this presentation. We're going to talk about people that remain homeless for a long period of time, a year or two. And what is it about them that keeps them homeless, and how can we help them? And this is an effort to kind of show that it only represents about 20% of the overall population, but in the public mind and also in public policy, if the public is thinking about it, politicians are thinking about it, the person who's on the street homeless with their belongings is the image of homelessness that most of the American public has in mind as that comes to mind when they think homeless. They don't think about homeless families in shelters or people in transitional. It's that solitary figure represents 80 or 90% of the public consciousness of what is homelessness. And that's the group that Housing First also targets. The system of care, the homeless industrial complex, is set up like a stairway. That's true for everybody. And it's because it's based on the assumption that people have individual problems. We have to fix them. We give them psychiatric treatment. We help them to sobriety. Eventually, they get housing. And some people do. 30 to 40% are able to manage that step-by-step process. But for people with chronic conditions, chronic addiction, chronic mental health, or severe mental health, there is a long history of trying and failing and relapsing and trying and failing and relapsing and returning to the street. And that is the group that ultimately we figured out we needed to do something else. And that is what Housing First is about. So Housing First, all of that as a preamble, Housing First is an alternate response to the mainstream traditional services, which are the staircase model. And how is it different? Well, it has three components. It has housing, permanent housing, not transitional housing or emergency housing, in the form of a rented apartment, a voucher, sometimes a building that's set aside that has a number of units for people experiencing homelessness. So it's housing. It also has robust support services. So it's housing first, but not housing only. There are robust support services, and the program philosophy is consumer driven. All of those things have to be present in order for the program to be legitimately called a Housing First program. Housing First recently has had a lot of dissemination more in name only. A lot of places call themselves Housing First, but unless you have at least these three core components, you really are not operating a Housing First program, and it would be hard to get the kinds of results that Housing First gets. The sort of, from a clinical perspective, what Housing First does is it reverses the power differential between the client and the provider. I would say almost uniformly across the staircase system, the provider calls the shots and the client complies. In Housing First, the client determines the sequence, the frequency of service, what they get first, and how long they get it. That's how we got to Housing First. It's a client-driven program. When someone is homeless and has all of these other conditions, and you ask them, how can I help you? And what would you like to do first? How can I help you first? They say housing. So that's the main practice philosophical shift, reversing the usual sequence of services. So people go literally from streets to homes. They might go into a bridge housing for a minute, but there's a voucher. They find an apartment integrated into the community. There are two program requirements. The person must agree to a home visit by the staff. We put people in with severe mental illness and addiction. We don't leave them alone. They must agree to that visit, and they have to meet the terms and conditions of a standard lease like everybody else. That's essentially the program. The kinds of services offered and most effective are the ones that are most flexible and most creatively aligned to the needs of the people. So even if your specialty is nursing or social work, it doesn't mean that you want to be stuck in that professional identity. You want to help the person find a church or a synagogue they can worship in, or go to the benefits office, or whatever it is that the client is asking for at the time is the best way to offer services. And often the request is of a practical nature or an everyday life nature. And of course, you get to do your treatment and support, but all in good time and at the pace and prioritization of the client, rather than the program driving the interactions. It's the client driving the interactions. The program has been studied a lot. Dr. Druss mentioned that it started in '92. We have had over 26 randomized controlled trials of this program, Stairway versus Housing First. And all of the results pretty much look like this: 80% success for people who are chronic going to housing first, compared to 30 to 40% using the staircase model. This has been replicated in Canada and France and other countries. Recently, the CDC in Atlanta did a what they call a systemic review of 26 randomized controlled trials, and they found housing first decreased homelessness by 88%, across all of those studies, if you do the program properly. Okay, I'm sorry, I probably took up more time than I should have. I'm going to turn it over. We're going to go city, state, and national. So my colleague, James Matthew from Milwaukee, is up next. He'll tell you how they used housing first in Milwaukee.
Great. Thank you, Sam, very much. I'm going to attempt to share my screen here. So, Sam, if you can nod your head, can you see my presentation? Excellent. Thank you very much. So good morning, everybody. Thank you again, Sam, for that great introduction to Housing First. So I'm going to briefly talk about how us at Milwaukee County use Housing First as really the sole response for our homelessness response here in Milwaukee, but specifically how we decided to take a leadership role in homelessness in our community from local government, and why we think that is important. Trying to advance my slides here. There we go. So a little bit about Milwaukee. So we have Milwaukee County is a population of almost a million people. Sam had brought up some of the racial equity issues around homelessness, and we focus on that a lot in Milwaukee County. We have pretty severe issues of segregation in our county, and African Americans are way overly represented in our homeless population. About 27% of the total population of Milwaukee County is African American. And as Sam mentioned, it's actually over 80% of individuals who are homeless are African American in our community. We also have kind of high poverty rates and just some other demographic information to give you background on Milwaukee. So what's unique about our approach, so I'm the administrator of housing services, and the unique thing about housing services is we are under the Department of Health and Human Services of Milwaukee County. So even though we're running all these housing programs, everything that we do here is under the lens of social determinants of health and looking at the quality of health outcomes for those in our housing programs. So on your screen here are the list of programs that are under our purview in housing services: community development block grant and home funds, continuum of care homeless programs. Our Milwaukee County Housing Authority is under our purview. Real estate development, eviction prevention, and for the purpose of today, our Housing First programs. So we're unique that in a lot of other communities, you have to talk to various agencies, various local government officials to get all these housing resources. Milwaukee County put all of these under one roof, under the Department of Health and Human Services, and we're able to cater all these different programs together to really have an effective homelessness response. And without local government leadership, we would not have been able to arrange all these different programs to meet the needs of those that we serve. And then for our outreach services, it's also unique for us. We do our own homeless outreach in Milwaukee County. So we have our homeless outreach has grown tremendously over the last few years. So we're unique that we're a local government agency that does its own homeless outreach and also does some of our own case management. So we have internal staff that do case management for our Housing First clients, and we also outsource some of that work to nonprofits. As Sam mentioned, what's weaved throughout all of our programs is always consumer choice. So our case management for outreach services and our Housing First programs is very, very flexible. We actually pay for it out of local tax levy for our very flexible case management slots, so individuals completely dictate their own treatment. It is always on their terms. It doesn't matter what's billable, what's not billable. We're always meeting clients where they're at. And if that level of case management is not appropriate for that individual, they need even more care, up to 7 days a week through an ACT team. One of the other service areas within our department is our behavioral health division, where that runs all of our mental health services. So we're able to interact division to move folks around for their appropriate services. So we started Housing First around 2014 with our plan to end chronic homelessness. And we had a little bit of a unique approach because there were a lot of business leaders in our community that wanted changes in our homelessness system. At the time, they were calling the police, arresting homeless individuals, and not seeing any results whatsoever on that. So our district attorney's office, our police department, and our businesses did not know what to do. So we had a downtown business symposium. Sam Sambaris actually came in as one of our guest speakers to really educate all these folks on Housing First and this brand new approach that we were going to take. And we started focusing all of our outreach and our housing efforts in our downtown business district, and had immediate results on homelessness. And what that did for us is very quickly businesses would begin to call our staff and our homeless outreach staff instead of law enforcement. And then fast forward to where we are today is we really completely decriminalize the issue of homelessness, and it is no longer ever a law enforcement response. Individuals are always calling our homeless outreach team now before law enforcement. So one of the first things we did, our initial funding was from our behavioral health division, again, a total separate division from Milwaukee County Housing Services. And they gave us $1 million to start Housing First of local tax levy. And why would a different division be funding something outside their own division like this? This slide shows why. So we're able to prove there's all kinds of national data around the effectiveness of Housing First, how it reduces emergency services, but we wanted to be able to prove that locally. And this was our way to do this. So we studied our first 85 participants in Housing First as it related to cost savings in emergency room services for the behavioral health division. And again, this is just for 85 individuals. So with that initial $1 million in investment, there was almost a $715,000 return on investment in 1 year just for those 85 individuals. Now we're serving thousands of individuals. So you can imagine the cost savings that we're seeing, not just through Medicaid, but also through local tax levy and the provision of those services here in Housing Services. So this is our most fun slide. So this slide shows where we were. Sam mentioned the point in time count, which is a federal mandate, and every January, literally counting every single homeless individual in shelter and unsheltered. So we have seen just a dramatic reduction in homelessness since adopting Housing First. We've seen about a 45% overall reduction in homelessness, but for the 2022 point in time count, we had a 92% reduction in unsheltered homelessness since we started Housing First. We're waiting for all the numbers in 2023 to become published across the country. Every community is seeing an increase in homelessness. A lot of that is due to the expiration of various CARES Act funding and stimulus funding from the federal government. But these were our numbers. And you literally see the era of when Housing First was started. And without question, the reason we've been successful in Milwaukee is really adhering to the true principles of the Housing First model. So we started obviously focusing on street homelessness and chronic homelessness. So that's really where we originally geared Housing First to, but we have really adopted the principles for every single area of homelessness, reentry housing, and even family homelessness. So this is not terribly public yet, but a few articles have picked up on it. One of our big partners in Milwaukee is United Way, and they've really taken the lead, kind of using our planning blueprint as an example. And Milwaukee is on track to declare the end of family homelessness at the end of 2023, again, led by our local United Way. Again, following true Housing First principles, every agency that United Way has funded has to sign a pledge that they're following Housing First principles that is being audited to make sure that's the case. But again, using this model, we have not had any unsheltered families now for about 3 years, and the time in shelter has been reduced by 72%. So we're following the United States Interagency Council on Homelessness guidelines to do this. But again, when the fidelity is completely followed with Housing First, it absolutely can be majorly successful. So an important thing that we try to do in Milwaukee is had, vast partnerships of organizations you wouldn't normally think of. So it was important to us, again, to have a leadership role in local government because we needed all these different partners. And the only way to do that was really to take a local lead. So these are our various partners in Housing First. I'll just call a few out that is unique. So our police department and county sheriff. County sheriff patrols all the county land and public parks. The Milwaukee Police Department, of course, everything else. But there is never an arrest of homeless individuals. All of our law enforcement partners will funnel all calls, any complaints through our homeless outreach team, and they will go out and actually do homeless outreach with us to encampments. It's been a great partnership. I mentioned our downtown businesses before. Our downtown business district actually funds a downtown homeless outreach worker on our government staff to do homeless outreach specifically in the business district. District Attorney's Office, waiving warrants for individuals on the streets. County parks, if there's ever homeless encampments in the parks, again, those department leaders will call our outreach team before anybody else. Two other ones I want to highlight. I don't want to go over time. Our HMOs and hospital systems, we receive over $1 million a year in revenue from our local HMOs and hospital systems. We provide housing navigation for their clients that are high utilizers of emergency services, and they've seen way more than a 3-to-1 return on their investment because individuals in Housing First are no longer using their emergency services. And the other important thing as it relates to this, we need to always make sure that the leaders of our Housing First programs are individuals with lived experience and those that we serve. So we have a resident advisory council that it's formerly homeless individuals that continue to be in our Housing First programs. They help write our policy, they help direct our strategy, and are really leaders in our division with our programs. So there's other agencies on this slide list as well. And the other important thing to think about, even though we're a government program, we're still fundraising for furniture and startup costs and all those different types of things that individuals need to be successful in their apartments. So I will stop there. Happy to take any questions later on in the presentation. So thank you. Back to you, Sam.
Thanks very much, Jim. Very good. Very good. Next, we have State. Maxwell, if you're ready, maybe tell us about your work at Georgia Department of Behavioral Health and Developmental Disabilities.
Hey there, everyone. Can you hear me okay? You can see the presentation? All right.
Yeah, yes, all good.
So my name is Maxwell Rupersberg. And our office is over these three programs. You're familiar probably with PATH and SOAR from SAMHSA, but this one is unique to Georgia, and it's the Georgia Housing Voucher Program. It's the one I'll be talking about with you today. But we recently, adopted the motto to really underline that housing is healthcare. And these are some of the value statements of our teams providing this kind of support that we try to underline with everyone, that, housing is a human right, and it's also the foundation for recovery. It's a new start. So don't worry, this is not a stairway model, but it is a stairway diagram that outlines the journey from, outreach, making contact with a provider, up until the point where they're housed and they're stable. And I'm going to use this later as an explanatory tool. So GHVP itself, tenant-based voucher program, it is permanent supportive housing. But there were some problems with our model that we wanted to change to make sure that we have the supportive part functioning correctly. This program was born out of the Olmsted settlement. that settlement happened around 2010. The state is actually still under supervision with DOJ. So I get to have some fun regular meetings with them about this. And so that's our target population. But in Georgia, and I'll show you the eligibility, it looks, a little different. It's unique to Georgia. So it is accessed by, connecting with our provider network and familiar characteristics where individuals not expected to pay more than 30%. We will accept individuals without any income, and we can pay for all of their rent. But those other costs still have to be taken into consideration for their stability. And it is a housing first model. So all of those characteristics of choice, no requirements for readiness, the lease is in the individual's name. But our eligibility, so someone has to have a diagnosis of serious and persistent mental illness, currently experiencing homelessness, or importantly, in a residential program or temporary housing. So we tried to be, we're trying to help folks who are also transitioning out of facilities, crisis facilities, hospitals, our own DBHDD, state psychiatric hospitals, as well as jails and prisons, and private hospitals, the latter three being much harder to access. So that represents really our target population, is they've got to meet one of these in addition to having a diagnosis and experiencing homelessness, or being in a transitional setting. We've made this include HUD-funded like rapid rehousing, since those are outside of our system. We are the behavioral health authority. We work really closely with the housing authority, which is the Department of Community Affairs and the COC system. But most individuals are coming into the program through chronic homelessness out of the community. But we've had to make a lot of partnerships around trying to reach folks in jails and prisons, to see if we can reach them and actually help them exit by meeting the terms of their release with a diagnosis and a lease in their name. Bridge funding is an important part of our program. It is flexible funding, and again, because we are state funded, and this is a $24 million program, GHVP is, although that's now maybe 26 in this fiscal year. So bridge funding is that gap funding. They're coming out of a situation of homelessness. They have no household furniture, application fees, utility deposits. So we've created a lot more options for that to be used to support folks, including some eviction prevention, landlord risk mitigation type program. We have some incentives now for landlords that are willing to participate. We can cover some property repairs if they're not passing HQS at first. And those are made on behalf of the individual, and that provider gets reimbursed from us. All in all, it represents about $13,000 in potential resources. Obviously, most households don't need all of that. But we do utilize the eviction prevention. We do utilize those incentives. And so the supportive part, right, is our housing support program. And that was really the missing piece of the puzzle for us to really be operating in a housing first model. And its goal, and taking on that responsibility for ongoing wellness. That was not provided for as effectively because there wasn't an infrastructure for billing for that work for our providers. So they may have been tasked with it, but if they can't make it make sense financially, that no longer serves as a priority. So we had to correct that. And I'll show you what those supports look like. But these supports, are tackling all of these areas, from the search to renewals, right, the ongoing, and then acting as a engagement tool, an encourager to reconnect with service, stay connected depending on their situation, in connection with other resources, right? And obviously housing stability, big picture. So this is back to the diagram. It's at this point where they get approved for the voucher that our support program is supposed to sweep in and be another layer of support for the clinical provider. They could decline further support from the clinical provider, right? That is optional. But that housing support program has to remain in place. That's the person who's going to be visiting them. And by doing that, it gives us an opportunity where that provider, by virtue of being a required component, is able to keep that individual enrolled if things are being done correctly with paperwork, and therefore bill for the visits and whatever escalation of support might be needed. And these are the billable services. It's this unbundled Medicaid supports, right? So they're billing under housing supports to Medicaid. Case management, peer supports, PSRI, psychosocial rehabilitation, right? Addictive disease crisis intervention, CRR4, something in our state, community transition planning. It won't surprise you that most of the billing that's been successful has been on case management, but we are 2 years into the rollout of this program, so we are learning a lot in navigating that. This is kind of the structure of those required wellness visits, that it's double intensity in the first 3 months, but then ongoing for the rest of the year, and then in perpetuity. It's meant to be minimum one person once a month in person, and one telephonic. Now that is the baseline, right? So it should be scalable up to a much higher level of visitation, dependent on the person's needs. And we do have a partnership and agreement with HUD so that folks have preferential access to the housing choice voucher. So for some folks, that's a good option, and they can fully transition off of GHVP to the HCV. But the housing supports will go away at that point. So it does have to be someone who's truly ready to leave behind the supports. Just some data real quick to show you is some of the growth that we've seen in the inflow. This is the last fiscal year, so part of year 2. And what we've seen has been way more assessments, efforts to connect people to the resource now that the support system is in place. And so we had big spikes in referral numbers and the ultimate vouchers being issued. We issued over 1,200 in the last fiscal year, which is huge. We don't operate with a wait list right now. And the goal is to not have to operate with a wait list, but that does require additional funding, of course. And so this has been our growth since FY22, from the high 1700s to now about 2,200. There has also been outflow at the same time, right? But we had about 600 people come on in the last fiscal year. But there are challenges and opportunities. So care coordination is a challenge, information sharing between providers, big challenge. You need the documents, one, to be able to provide good care, but also for the administrative things that we need to happen and work, right? The documentation, the billing, the getting enrolled, so that we can make it more sustainable and serve more people. So we have to, draw those lines to understand that if we want this to work as in the system that we have, Georgia's, not Medicaid expansion, we do have to hit some goal points. Individuals without income is a big challenge. Voucher acceptance by properties. We do need to get folks approved for Medicaid for the billing to be able to even be an option, right? And a big opportunity that we're working on is trying to connect EMRs and the statewide HMIS system that we have in Georgia, which is not something many states have the advantage of, to our state's health information exchange, to hopefully be able to facilitate closed loop referrals between and across our systems, to really bring down those barriers between behavioral health and homeless service system. All right, that's it for me. Stop sharing.
Thanks very much, Maxwell. Nice presentation. If we were on campus, I know you're an Emory alum, I would have. Example of what can happen when there's collaboration at government at the top levels. Anthony Love.
Hi, Sam. Can you hear me?
Yes.
Okay, I thought my screen had frozen there for a minute. So I'll try to be very brief, so to give people an opportunity to ask questions. Anthony Love with the Department of Veterans Affairs. And so I will just jump right in and first start off with giving you a brief overview of the state of homelessness among veterans. And so per the 2022 point in time count, over 33,000 veterans were experiencing homelessness on a given night. This, although that's a large number, it is in fact an 11% decrease from 2020. And since 2010, there has been a 55% decrease in the number of veterans experiencing homelessness. As we move forward with our vision and our mission being to end homelessness for all veterans, we have worked with strategic partners within the federal government, the U.S. Interagency Council on Homelessness, and the Department of Housing and Urban Development to determine what it would look like for communities to effectively end homelessness among veterans. And since we put that criteria, those criterion benchmarks in place since 2015, 83 communities in 3 states have met that criterion benchmark and have effectively achieved an end to veteran homelessness, which means that they have systems in place that they can prevent homelessness for veterans whenever possible, quickly rehouse those where there's housing insecurity and they may lose that home, so they can quickly rehouse. And they also have a system that will sustain those veterans who have been effectively housed. The VA itself, we offer a wide array of interventions designed to find veterans who are homeless, engage them in services, and then find pathways to permanent housing and prevent homelessness from occurring. A number of those programs, some of you may or may not have heard of, they are not necessarily permanent housing, but they do use the principles that align with housing first. But the one program that does engage veterans and provide permanent housing is what we call our HUD-VASH program. For those who've not heard of HUD-VASH and know what HUD-VASH is, it is a collaboration between the Department of Housing and Urban Development and the Department of Veterans Affairs. It's a Housing and Urban Development Veterans Affairs Supportive Housing Program, HUD-VASH. And the role of each of this particular program, it is to move veterans and their families out of homelessness and into permanent housing while promoting maximum veteran recovery and independence in the community. So the role of the 2 agencies involved in this is that HUD provides the resources for rental assistance through its Housing Choice Voucher Program, which is administered by local public housing authorities throughout the country. Same goes for VA. VA provides the clinical case management and supportive services to assist those veterans who have a voucher and been housed. And these services are delivered through our local VA medical centers. This is really a monumental thing because you have 2 federal government agencies who have a real stake in the success of veterans exiting homelessness. Just to give a little background on this particular program, HUD-VASH was actually established in the 1990s, but it did not receive strong federal support for many years. However, in 2007, Congress began to fund these special purpose vouchers, these HUD-VASH vouchers, in earnest, and was under what we call the HUD Appropriations Act. The funding for these vouchers was about $75 million. It funded about 10,000 vouchers at that time. And some would say that this was done in part due to the increasing number of veterans who were beginning to return from Iraq and Afghanistan. And also, if you remember during that time, our economy was in real trouble. And there were concerns that these veterans may become homeless. You also can use these vouchers to prevent those who may become homeless. And so, again, the role of the PHA in this is not only to administer those vouchers, but they are to screen for two factors, for income eligibility, to make sure that the veteran meets the income criteria, has to be very low income, and that the veteran is not on a lifetime sex offender registry. Those are really the only 2 criteria that really the Public Housing Authority should screen for. Our role at VA is to provide a clinical case management model, which is not time limited. It assists veterans in obtaining and maintaining housing. It varies in intensity based on the need and the desire and for that veteran, and supports treatment engagement and community integration, and helping the veteran set goals for what he or she desires in that space. The HUD-VASH program targets those veterans with the greatest need and with the most vulnerability. Those are the ones that we target, although they're not the only ones that are in the HUD-VASH program. In addition, some HUD-VASH programs have specific population focus, including aging and disabled veterans, and or American Indian and Alaska Native veterans through what we call our tribal HUD-VASH. How is HUD-VASH housing is a housing first program? So HUD-VASH is guided by housing first principles, such as rapid placement into housing. So the idea is to not only engage that veteran, but to move that veteran through as quickly as possible and get them into housing as quickly as possible. Not placing any prerequisites for abstinence of substances or so forth, for entering housing, having minimal requirements for engagement in clinical care. And this is how HUD-VASH effectively works to end homelessness among these veterans. HUD-VASH also utilizes a variety of strategies to increase access to housing while reducing barriers, including but not limited to a harm reduction approach, no expectations that veterans participate in treatment or seek recovery in order to obtain housing or to maintain housing if medical or mental health substance use issues are not impacting their participation in the HUD-VASH and housing space. And also making sure the veteran has choices and their self-determination for that veteran. And lastly, but not least, recovery orientation in terms of recovering from those things that may have been barriers to that veteran in terms of being able to exit homelessness. And so just to give a little data, HUD-VASH currently has over 110,000 vouchers that have been allocated to the program since 2007 for the veterans' use, and it operates in all 50 states, as well as in Guam, Puerto Rico, and the U.S. Virgin Islands. And just a little bit, as you've heard with homelessness, that there is disparities with folks who are Black or African American, are American Indian or Alaska Native. The HUD-VASH program, what we've seen is that 48% of those veterans we served are white, 40% are Black or African American, and 3% are American Indian or Alaska Native, which also falls in line with the proportionate number of veterans who fall into those categories. Also, if you break it down by gender, 87% are male and 12% are female who are receiving these particular services. So I just wanted to go through that really quickly to just give a sense of how HUD-VASH is helping veterans to move them out. Right now, there are over 80,000 plus veterans who are under lease with a HUD-VASH voucher. And there are other veterans with vouchers in hand who are looking. And so we are using flexibilities and so forth to ensure that those veterans get into housing as quickly as possible. And one thing I didn't mention that's not required of them is that they don't necessarily have to have income in order to get into housing. Our case managers would work with them to make sure they get the resources that they need so that they can provide the support, their portion of the rent that is available. So I'll stop right there because I see that we're at 12:54. I tried to move really quickly. You
did great. Everybody did great. We have like 6 minutes for questions. I just have one. Just want to confirm this with you, Anthony. 3 states and 83 cities have ended veterans homelessness. Is that accurate?
Yes. I always say effectively end veteran homelessness because people will say, "Oh, you mean there's zero?" No, it's not zero.
No, it's like functional zero.
Yeah, functional zero. Exactly.
Right, and that's a point that that I want to make even with the numbers early on, that the number of people who are homeless is not a fixed number. I mean, even at one point in time count, people are flowing into homelessness and flowing out of homelessness. It's a river. It's not a pool. It's a stream. So we have to think about prevention, even though the programs we just heard about reduce homelessness. We can reduce homelessness forever unless we shut off the stream of the systemic issues where people are pouring into homelessness. We'll be in the homelessness ending business in perpetuity. But it's an amazing program in terms of its magnitude, 50%, 56% reduction nationally, 83 cities and 3 states. It's awesome. So Dr. Druss, back to you. I don't know if there's questions in the chat. I haven't had a chance to look, or if people have any comments to any one of the presenters. Welcome.
Yeah, I'm not seeing questions yet, but feel free. We probably have time for a question if people have it. Maybe I'll just lead off with one that I was wondering. So many of you have been doing. First of all, just amazing presentations, really nice organization, kind of fit together so nicely. Many of you have been working in this space a long time. Obviously there's been a change in the housing market that a lot of you guys are up against. I'm just wondering how that's affected what you do, how you're able to do it in terms of providing supportive housing to your population.
Awesome. James, do you want to, you're probably closest to the field.
Sure. That's a great question. So we did have to pivot because of the housing market. So the vacancy rates in Milwaukee dramatically changed over the past couple of years as rents increased. So we used a recent round of home stimulus funds that a lot of communities got. And the biggest thing we did is we started up a landlord engagement coordinator, as well as hired a few housing navigators. So what we found through the work of our landlord engagement coordinator, her job is literally just landlord recruitment and engagement. And we heard from a lot of our partners, there's no 1-bedroom apartments available. They're all free. With her dedicated work reaching out to landlords, there were a lot more vacant apartments than we ever thought they would be because of her laser focused approach on just landlord engagement. It changed an awful lot for us. And the most recent example, we thought we had no vacancies, and within an hour and a half of an email blast, we had 40 vacant 1-bedroom apartments to look at. So again, there's always a little more capacity if you're creative, but the landlord engagement coordinator was our biggest win lately.
Mm-hmm.
That's wonderful.
There is a question in the chat here about how can I get consumers to get registered with the program. I'm not sure exactly what program. I mean, the one in Milwaukee, the one in Georgia, the HUD VASH program. They're all different. And while we're thinking about that, Maxwell, do you want to weigh in on this particular issue?
Yeah, so we have been affected. We have had to adopt, the landlord risk mitigation incentives. I think we'd be farther behind the ball if we hadn't already been moving towards those. But so obviously affordability is always a problem. One of the bigger systemic things that we're seeing that gives me a lot of concern is something that Sam alluded to, where there's being purchases of large commercial properties, multifamily properties, and a corporate level policy is basically pushing against continued acceptance of vouchers. And they're looking to push the current voucher holders out, re-up at the new market rates. And that's a problem. It was already a barrier to finding properties, but when you get kind of large system movements against those options, we end up with 15 people that are at a large property that all need to be relocated suddenly in a matter of a couple months, because you can get kicked out of your apartment pretty quickly in Georgia. So yeah, that's been one of the biggest concerns.
Well, it's huge nationally. I think if we don't have a state, municipal, or federal policy around capping rents, and we let the entire real estate market go to market, and let it float the way it's happening right now, we're going to be looking at a lot bigger problems than we have today.
Thank you so much. So Stephanie, if you're on, I think we're out of time for questions, and I want to be respectful of people's time. Do you want to close us out?
Yeah,
And
sure.
just want to first say thank you again. It was a really wonderful panel.
Yes, the Southeast MHTT extends our deepest thanks to our panelists today for sharing about the programs addressing homelessness at the city, state, and federal level. To our attendees, we appreciate you joining today. We do invite you to provide feedback and fill out a brief SAMHSA required survey. We're pasting that link in the chat right now. Completion of that survey provides information to SAMHSA and assists us in planning future events. You will be automatically redirected to a few more questions from the Southeast MHTTC. And at that second survey, you'll be presented the opportunity to download a certificate of attendance for your records. Please allow 5 to 10 seconds for your browsers to load between those surveys. Again, thank you all for joining us today. Thank you to our panelists. And that concludes today's event. Take care.
Thanks, everyone.